Good afternoon, everybody, and thanks for joining us. We'll give just a couple of minutes here before we get started to let everybody load in. All righty. Good afternoon, and thank you, everybody, for joining us for today's webinar, Interpreting CMS's Cost Performance Feedback. I'd like to let everybody know that the information contained in this presentation is for general information purposes only and does not attempt to provide medical, mental health, or any other type of healthcare service. This presentation is not intended to be an alternative to medical treatment, and the content of this webinar may not apply directly to specific circumstances. The information is provided by UK Healthcare's Kentucky Regional Extension Center, and while we endeavor to keep this information up to date and correct, we make no representations or warranty of any kind, express or implied, about the completeness, accuracy, reliability, or suitability with respect to content. So here at the Kentucky Regional Extension Center, we strive to serve as the trusted advisor to healthcare organizations, clinicians, and leaders across the Bluegrass. As you can see, we have partnered with organizations in almost every county in the state to improve the quality of care, reduce the cost of delivery, and improve the overall well-being of the Commonwealth. We have advisors located across the state within your communities that understand the challenges you may be facing. Let us be your resource as we all work together to build a healthier Kentucky. Our presenters today are myself, Jared Deason, and I'm joined by my lovely colleagues, Jessica Elliott and Robin Kern. So cost can be an overwhelming category. You don't generate any reports to look at monthly or quarterly like you would to monitor quality or promoting interoperability. It's solely based off of claims that have been submitted through your billing department to CMS. Real-time feedback has always been rather elusive, so it's been hard to really tackle where to go and what to do with the data that you do have. Our goal today is to really help you better understand the category basics, the different types of cost measures that are out there, how and where to get your reports, and lastly, how you can use the feedback from your MIPS final reports to dig into patient populations to improve their overall outcome and manage costs. So getting started here, the category is weighted at 30% for traditional MIPS and MVPs for both small and large practices. If you participate in QPP through the APM pathway, cost is technically weighted at 0. Now, this does not mean you aren't assessed on cost. Those participating with an APM decide upon cost at the time of signing that contractual agreement when joining an APM. And the percent of risk can vary from organization to organization. So to give a brief overview of costs for 2024, there were 5 new measures that were added through rulemaking. These episode-based measures are depression, emergency medicine, heart failure, lower back pain, and psychosis and related conditions. For traditional MIPS, eligible clinicians will be scored on cost measures where they meet case minimums. These case minimums are measure-specific and can be anywhere from 10 to 35 cases. If you do not meet case minimums for any cost measure, costs will be reweighted to the remaining categories that you are attesting to. Simple pneumonia with hospitalization was removed for 2024. The cost performance category is a composite score, and to trigger cost category assessment, case minimums must be met for at least one of those measures. Each measure is worth up to 10 points. There is improvement in scoring attached to the cost category worth up to 1% percentage point of your raw score, and CMS does this by comparing your previous year's score to your current year's score. So as I stated, for traditional MIPS, eligible clinicians can be scored on any of the measures that they meet case minimums for. But for those of you performing in MVPs, you will be assessed only on the cost measures that are attached with that specific MVP. So this slide here shows all 29 of the cost measures within the category. I encourage you to take a look at this and compare it with the types of procedures that clinicians are doing in your practice. This is going to give you a better understanding of which measures you might actually be assessed on. So with attribution, generally attribution is based on the codes that you are billing and the services rendered within a window or time frame for a Medicare beneficiary. Predicting this can be a challenge, as providers and services can change from year to year, and your feedback reports can be helpful here, and reviewing what measures you have pulled in the past can give you a good assumption of what you can plan to be scored on in the future. Each measure has its own window for attribution, triggering events, and associated billing codes at either the 10 or 10 MPI level. Familiarizing yourself with the measure specifications that you think that are applicable is the best way to prepare ahead of time for the cost category. This is going to help you understand which billing codes are going to trigger for each measure and what those attribution windows look like. So now that we've got the general understanding of the cost category, let's walk through some of the actual measures. We will kick it off here with episode-based measures. Episode-based cost measures represent the cost to Medicare for items and services furnished to a patient during an episode of care. Cost refers to the standardized Medicare allowed amount, which include Medicare payments and any co-insurance or deductibles as well. The intent is to measure clinicians' resource use based only on those costs that occur as part of an attributed clinician's care management. Currently, there are 4 types of episode groups that serve as the basis for cost measures. There are 15 procedural episode groups that assess the cost of care that's clinically related to a specific procedure provided, such as surgeries, during an episode's time frame. All procedural episode measures have 10 episode case minimums, except for the colon and rectal resection measure, which has a case minimum of 20 episodes. This data is obtained by Medicare Part A and B claims. There are 6 acute inpatient medical condition episode groups that represent treatment for self-limited acute illness or treatment for flares or exacerbation of conditions that require a hospital stay. There is a 20 episode case minimum for acute inpatient condition episode-based measures, and data comes from Medicare Part A and B for all acute inpatient condition episode-based cost measures. For sepsis, they also add in Medicare Part D claims. There are 5 chronic condition episode groups that assess the cost of care clinically related to the care and management of patients. Specific chronic conditions provided during a total attribution window divided into episodes. There are 20 episode case minimums for chronic condition episode-based measures, and it comes from your Medicare Part A, B, and D claims data. Our newest measure is centered around a setting of care rather than a unique condition or procedure, specifically centered around comprehensively assessing emergency department care, and focuses on the care that's provided by clinicians in emergency departments, and includes visits leading to both discharges and hospital admissions. This measure has a 20 episode case minimum and comes from Medicare Part A and B claims data. So let's walk through a quick example here of an episode-based measure. This measure is chronic asthma COPD, and this measures clinicians, the clinicians that are billing more than 30% of trigger and confirming claims that are condition related to the patient prior or on the episode start date will be attributed. This measure also requires that clinicians must have at least 2 condition-related medications prescribed to 2 different patients during the current and prior performance period. In this example, these medications could be corticosteroids, bronchodilators, for example, to at least 2 of those patients in the current performance year and previous years, which would establish a relationship with that patient. As we look at this example, we can see that this patient saw 3 different clinicians. They saw clinician A for a regular office visit, maybe coming in complaining about his or her asthma. This prompted clinician A to do some pulmonology testing. The patient then saw clinician B, who is in the same group, for further testing and a later office visit. The patient then went back to clinician A to follow up and had further labs done. And lastly, the patient was prompted to see clinician C for physical therapy for an unrelated issue. Based on this example, both clinician A and B would be attributed this patient as they are billing at least 30% of those triggering or confirming claims during this specific episode of care. Clinician C would not be attributed this patient as they only billed 2 claims during this episode, and it was for an unrelated care. With that, I will now hand it over to Jessica, and she's going to give us some insight on Medicare spending per beneficiary.
Thank you so much, Jared. So Medicare spending per beneficiary. So the episode-based measures that Jared talked about, those are relatively newer to the program. Medicare spending per beneficiary, as well as total per capita costs, are kind of our OG measures that have been around with the program for quite a while now. And Medicare spending per beneficiary clinician is a measure that is a pretty far-reaching measure in and of itself. It applies both to clinicians, inpatient clinicians in that hospital setting, and it can also apply to outpatient ambulatory care and can be applied and attributed to multiple clinicians in either setting. When you're talking about an MSPB-C triggering event, or what they call an index admission, it is focused and looking at that inpatient stay. That's a qualifying inpatient stay. So that's that index admission. And what that does, it triggers an episode window. So CMS is going to look back at all parts A and B, and they're going to look at what happened 3 days before that admission, and they're going to look at what's happening 30 days post-discharge from that index admission. So that is the overall depth and breadth of that episode and all of the parts A and B charges that are going into it, regardless of care setting. Now, if you are receiving some type of care in that post-discharge window that doesn't have anything to do with that index admission, CMS is not going to attribute those encounters, those E&M codes into your overall MSPB-C assessment. But if, say, that patient goes to the emergency department within that 30 days related to that index admission, say they have a wound dehiscence, or they have some other type of re-injury related to that index admission, that is going to be attributed. Also, if that patient gets readmitted during that 30-day window, the clock starts again. And so then you'll get, once that patient is discharged, you'll get an additional 30 days of discharge period. So it can actually, if that patient is very complicated, you can actually have a lot of charges around that index admission. So again, this is really looking at the total costs of care around a specific inpatient stay. And so the way CMS identifies and really kind of goes through this process to identify those patients who qualify for this measure, they are going to look at the both medical and surgical episodes related to their beneficiaries. They're going to look at those for the medical-based episodes, those medical admissions. They're going to look at those E&M codes that are billed during that admission and around those windows. And then for surgical, they are going to be, again, looking at any of those CPT or HCPCS codes related both at that tax ID and that clinician level. Then CMS actually goes to attributing to the clinician. So it looks at that 10 level, and then it goes down to the clinicians. And so if you have billed greater than 30% of the E&M services for that medical index admission, you would be attributed that patient's cost. Surgical, it's going to look at who is billing relevant CPT and HCPCS codes to be able to attribute those clinicians to it. So it can be both your hospitalist, your primary care. It can be your specialists that are involved in that care, both in that inpatient and outpatient realm. There's also some exclusions that are built in. These are going to actually just only remove a small subset of your patients from the cost measure calculation, for those patients where it might be impractical or unfair to compare costs of care for those patients at large. And so there are some exclusions that are factored in, but it's not necessarily clinician-based exclusions. It's more patient-based. And then finally, CMS does do risk adjustment, as with all of their measures. They want to try to reduce that variation in clinician costs to really be able to only identify those costs that a physician could reasonably influence. So you're not going to have those costs associated with a condition that's or an E&M line that doesn't relate back to that index admission. So let's talk a little bit further about the actual attribution, because I think it's good to sometimes have a visual of what that looks like. So when we're talking about the medical, looking at the MSDRGs, those E&M service codes that are billed during that index admission and during that window, you have, in this example, you have 3 different tax IDs. You have 2 different tax IDs, but 3 clinicians. So in 10, that organization A, you have 2 clinicians. In organization B, you have 1 clinician. So if we dive down into that second line for 10A, they have billed 71% of the total charges related to that patient's care. And clinician 1 billed 31%, whereas clinician 2 billed 12%. So those clinicians would be attributed under that tax ID. Now, if you look at 10B, you have 29% of the charges that are billed. Now, again, we remember that threshold is 30%. So therefore, 10B and those clinicians would not be attributed. Again, it's about meeting that plurality of visits, about creating a majority or a significant portion of the care. So you can have 2 different tax IDs potentially being scored on the same patient. You can have multiple clinicians within a tax ID being scored and evaluated on a patient. Now, when we're looking at surgical attribution, we're just looking at this example, we're just looking at a single tax ID and we have 2 different clinicians. So when CMS looks at it, they look at that 10 level and they've identified, yes, that there are relevant CPT and HCPCS codes that have been billed under that tax ID. So that that tax ID would be attributed that patient. So if we look at the more granular level of the clinician, we can see that clinician 1, they did bill under that tax ID, those relevant HCPCS codes related to a surgical index admission, and so they become attributed. Whereas clinician 2 didn't bill anything, they're not involved in the care, so they would not be, their score, their performance would not aggregate and roll up under the tax ID. So that's how you can see at the individual clinician level how that influences and impacts what gets counted for that 10 and what helps meet that episode case minimum. Because remember, with Medicare spending per beneficiary, they are going to be looking at 35 episodes, whether it's medical or whether it's surgical, to be attributed either to the clinician or to that tax ID for scoring purposes. One last thing I want to talk to you about is the patient level data that we can receive from CMS. So this right here is a de-identified screenshot taken from an historical feedback report for CMS. And this has, again, had the beneficiary information removed, date of birth, their beneficiary ID, all of that is typically found in this file, but we de-identified it for our purposes today. More is just an explanation for you all to be able to see what information is available from CMS. Now, you may have, if you've submitted cost in previous performance years, you should have access to these reports. If you did not submit for cost, if you took an EUC, perhaps last year or the year before, you wouldn't necessarily have access to this data. You might have just a high level overview of what you could have scored had you been assessed on it. But this is actually at the individual beneficiary level detail. This is going to provide some really valuable information for you all related to this particular measure and what rolls up into it. So it's going to show things like for each individual patient, what is their HCC score rank? And so that percentile rank is going to be from 0 to 100%. Obviously, those patients with a higher HCC score, a higher rank, mean that they are going to be higher utilizers of services, that there are going to be more charges that are associated with them. And a lot of times we see that it's not just that inpatient stay, but it's ED utilization. It could be imaging, it could be skilled nursing, outpatient claims, that all of those different areas that could roll up into that episode window. It's going to show any of those associated charges for that window. And so you can see all those different categories across. I know that the font's really small, but we just wanted to give you an example of how it crosses both the inpatient and the ambulatory realm. One of the things that you can do whenever you do receive this patient level data is that you want to be able to kind of slice and dice this. You want to be able to look at the provider that is providing care to our patients. Do you have, look at the ratio of providers that you have with patients with a higher HCC score. Typically, your patients with a HCC percentile of 70 or higher are going to be the ones that typically impact and influence this particular measure. Do you have, just a couple providers that are carrying the weight of these patients with that medical complexity? If so, you can start to take a look at how do you distribute panels? How do you account for and provide extra resources to those clinicians to be able to help better manage their patient populations or to help support them in the management of their populations? You also want to be able to try to look at, especially your high utilizers. If you sort by like their HCC percentile and also the cost per episode, you can help identify and look through those patients and be able to see, what are their diagnoses? What are the reasons why they had that index admission? To be able to identify any sort of trends with this data so that you can be able to provide some resources. So say if you notice that a lot of your patients who are scoring really high on that episode, the cost per episode on this report, if they are higher utilizers of the emergency department, or they have experienced a readmission related to that particular index admission, it's an opportunity for your organization to look at how you are handling transitions of care. Are you billing for TCM? Are you able to make contact and get that patient seen within their primary care setting or with that specialty care within 7 days of discharge? So there's different interventions that you can employ to really help identify a particular patient with their diagnosis and how to kind of mitigate that, or to be able to provide resources to your clinicians who are attributing the most cost to this particular measure. Now, with that, I want to hand it over to Robin Kernel, and she's going to walk us through total per capita cost.
Thanks, Jessica. So we got lots of terms in understanding cost measures. Jessica talked about windows. I'm going to talk about candidate events. So as she said, total per capita cost has been around since the inception of the cost category. We consider total per capita and Medicare spending as sort of our global measures because they can touch every provider versus some of the episode-based measures are very specific to specialty and practice type. So when we think about total per capita cost, we're talking about primary care services. And in this case, we also talk about risk windows. So we have an E&M primary care service that's been paired with at least an additional primary care service or a second E&M code that trigger the opening of a risk window. These windows actually cover a full year. So when you have the opening event or the candidate event, it can actually cover for a full year after that date of that initial event. So risk window begins from the first qualifying candidate event, and it is the first episode of an E&M in a primary care service. It covers for a full year from that first event. However, a single candidate event does not equate with a beneficiary being automatically attributed to this measure. Total per capita cost looks for plurality of primary care services. Candidate events are defined as an evaluation and management care service paired with one or more additional primary care services. So you can have the evaluation and management care codes and a care service, or you could have multiple E&M codes with primary care services. Multiple ways to make this up. You can have clinicians excluded from attribution if they meet some of the criteria for one or more of those service exclusions. They're going to fall under the following categories of surgery, anesthesia, therapeutic radiation, and chemotherapy. And they can also be excluded based on their HISCA specialty designation if they identify as one or more of those 49 specialties. So obviously we're not covering all of those specialties, but there is a specialty exclusion list. The risk window begins on the date of that candidate event, and it continues until 1 year after that date. So keep in mind they can look in previous and past years. It doesn't all have to fall in the current year. A beneficiary's costs are attributed to a clinician during the months where the risk window and the measurement period overlap. All beneficiary costs occurring during those covered months are attributed to the remaining eligible tax IDs. And so we look at it from a tax ID NPI attribution level, and only the NPI or clinician responsible for the plurality of those candidate events provided to that beneficiary is attributed those costs. So they may look at it from the group level, but whichever provider within the practice that provides the most care to that patient is going to be attributed to that patient. And then we look at monthly observed costs. They're payment standardized to account for differences in payment rates from Medicare, because we know Medicare doesn't pay the same on multiple, they don't pay the same based on multiple different reasons. They have payment calculations based on urban and rural. And then all standardized costs from services starting in a beneficiary month are assigned. And then finally, we have risk adjustments and specialty adjustment. All play into total per capita cost and how it's assigned to the clinician. And this is regardless of how the care is provided, there is risk adjustment applied to the medical cost, and then specialty adjustment is applied monthly as it applies to those tax IDs with those varying specialty compositions. So think of it from a practice perspective. If you have a multi-specialty practice and how those clinicians work together to care for that patient, CMS adjusts for that specialty care provided. So we're going to look at an example here of how attribution applies. So in this example, we're looking at the clinician billing evaluation and management services with a primary care service. And with this beneficiary, we can see that we have providers from cardiology, optometry, family practice, and geriatric medicine. Each of those clinicians had at least one qualifying event within the risk window. And we can also see that from the list of exclusions that cardiology is excluded due to the events falling within a global surgery service period. So remember I said there's groups who are excluded. And in this case, because the patient had some type of surgical service during this event, the cardiology practice has been excluded.
I'm having to change my audio. Give me just a second. Okay. Can you hear me okay still? Jessica, give me a thumbs up or something.
You sound good, Robin.
Okay, I've had to swap, sorry. So back to our providers here and how they are being attributed. So because this cardiologist builds some primary care services codes during this time that this patient had a surgical service, they're excluded from having this patient attributed to them. Same thing for optometry. They build some E&M codes with some primary care services somehow attached. They're excluded due to being a specialty. So they are not attributed this patient. When we start looking at family practice and geriatric medicine, we can see that both of those providers had qualifying events. They do not meet any of the exclusions, and both clinicians will be attributed to this. Both clinicians will be attributed this patient. So to flip that around, a patient can be attributed to multiple providers under the total per capita cost measure. So moving along. So Jessica showed you an example earlier from Medicare spending per beneficiary. A total per capita cost looks very similar in how you download that data. However, the information is different. You do get HCC scores for each attributed beneficiary, similar to what you get in the Medicare spending. Keep in mind that the higher the HCC score, the more medically complex the patient is. Those are generally your higher users of care. Total per capita cost looks at all primary care services provided to the beneficiary, and it will associate, if it can, that beneficiary to 4 different diagnosis groups. And you can see those listed here: diabetes, coronary artery disease, COPD, and heart failure. If the patient falls in one of those, you'll be able to say, it'll say true. So it's a yes or a no, but it's true or false. And then we look at cost associated for that patient within that risk window time, or candidate event risk window. And it does include other outpatient services, anything that may fall inpatient wise that may be applicable to whatever is appropriate for that patient. So again, you can dive into this data within those reports and find your high users of care. You can use it to target your population health initiatives. If you see that you have a large amount of folks who suffer from COPD or heart failure, in our example here we don't. In our example that we provide here, most of our patients fall having a diagnosis of diabetes. That allows you to focus certain groups and target some interventions towards that group of people. When we talk about these reports, as you get them, they are generally, I don't want to say the same every year because patients come and go in your practice and what have you. But overall, with these 2 measures, you can generally say if you've been scored on them in the past, it's very likely you'll be scored on them in the future. Hopefully that moves away for some of the specialty practices because we've seen those folks measured on total per capita cost. Ideally, you're not doing primary care services, but sometimes providers see a specialist more, or not providers, sometimes patients see a specialist more during the year than they do their primary care. And we all know that, and you all know that as well too. That's just where their focus gets moved to. So let's talk about accessing your reports. Now, in the grand scheme of things, CMS has told us that your 2023 preliminary feedback reports would be available in June. Well, it's not. So far, as of before this call today, they've still not been released. And we have folks that are checking every day. Both our team inside and some of our clients look every day for this. So provided they don't make any significant changes in how we access our report, we're going to go through today about how we do that and what to look for. And then, your advisor will also work with you once these get released too, to kind of drill down into things. So the left blue banner on your QPP portal we will see practice feedback, and it's going to give us the overview, and then each of the categories will be listed underneath of those, and you'll be able to select directly on cost. Now, some folks were able to claim an EUC for cost for 2023. Not all of our folks did that, but some have. For 2024, CMS has not released a COVID-19 related exception or hardship. So I don't think we can fall back on that this year. So we have to take into account that we're very likely going to get scored on 2024. So if you haven't been before, it's very likely 2024 could be your first year. So we're going to talk about accessing these reports. As I said earlier, you click on that left blue banner, it'll give you the category itself. It'll open just like we've saw in the past, and we'll have the option to click on view details. In this case, it would be here under the cost category. And we're going to see several things on that screen when that opens. So generally, cost is going to count for 30% of your final score unless it gets reweighted. So just keep that in mind, 30% of your final score. When we look at how they calculate the score at the bottom, it looks a little different than the other categories. For whatever reason, they keep Medicare spending and total per capita cost. Those measures are scored and added together. All of the cost category measures are eligible for 10 points. That's the most you could get per measure. They will, in this case, that's practice got 11 out of 20. Now, we can't tell from here if they got measured on both Medicare spending and total per capita, but I feel like they did by the way the score has laid out here. And then we can see for episode-based cost measures, they had 141 points out of a possible 240. So when we are scored on cost measures, while we know that there's 29 possible for the year, you are only scored on those that are applicable to your practice. So using this example, CMS says that this practice was eligible to be scored on 24 measures. And out of those 24 measures, their achievement points was 141 total. So CMS adds Medicare spending plus episode based, and then divide that by the total points possible. So in this case, 240. In the example, they've made the math very complicated. We would not have done that. Now, also, what could show up here is if you are eligible for improvement points. They will be in this cost score calculation at the bottom of the screen. And improvement points, you're eligible for those if you're scored on cost in the previous year and your raw category score is higher. So in this case, if you were scored in 2022 and you're scored in 2023 for cost, when they look at that, if 23 is higher than what your score was in 2022, then that makes you eligible for some improvement points and they would fall here. That is obviously not in our example. So when we're looking specifically at feedback reports, again, this is not the same example as we just saw because the scoring is clearly different. But you'll see the cost score here at the top, and then you'll see all of the measures. Now, it's a bit of a misnomer when it says submitted measures because you all are physically not submitting data. All of this is pulled from your claims that you submit throughout the year. Again, they're supposed to release our patient level cost measure report late this summer. When that does occur, we will work with you on how to interpret your reports here. At each measure has this drop down caret. It provides us very detailed information for the scoring. As you can see here, it gives you measure info and it gives you the eligible number of episodes, what their unadjusted score or unadjusted episode cost is, the ratio of what your unadjusted episode cost is against what Medicare says it should be. and then any points attributed, and then what comes from your benchmarking. There would also be a benchmark here. And then in blue, we would see this little link that says download beneficiary level data. You'd click that and it opens into this CSV file that we gave you a screenshot here. And obviously it's not in a readable format for today, but just to give you an example. So again, as we've talked about case minimums, in order to be scored, you're going to have meet the eligible case minimums before you're scored on a measure. And each of them, as we mentioned earlier, are different. For total per capita cost, it looks very similar. Again, you've got your cost here associated per episode, and then your score based on how you fall within the benchmarking, your number of eligible beneficiaries, what that ratio looks like of what CMS says your cost should have been versus what it actually was, and then your score. Again, similar, pulls out into a CSV file when you download it. There are some notes under there of some excluded patients. Again, you'll have HCC scores so that you can identify your high users of care. If you don't meet case minimum for any of those cost measures, or if a benchmark isn't established, then you're not scored on that in this performance category. If for some reason you are not scored on cost, then that 30% or 30 points of that final cost score gets redistributed between quality and promoting interoperability. In years past, we've heard about where the full points all land to quality. This is one of those years that CMS has made some more adjustments to how they reweight certain categories. And in this case, for traditional MIPS scoring in a non-small practice, if you are not scored on cost, it gets redistributed to quality and promoting interoperability. So what happens if we do get your feedback reports and there's some questions about them? Then we're going to help you submit a targeted review. There are several valid reasons of which to request a targeted review. Maybe the data was, submitted under a wrong tax ID or NPI. Maybe you didn't submit data, but someone else did on behalf of some of your providers. We have had that happen. This special status designation has occurred as well. Some folks don't get accurately designated as small or rural. So those are some reasons to request one. And there's other reasons why you shouldn't. Just because you disagree with how benchmarking was used to determine your score doesn't count for a targeted review process. Score changes, one of the things CMS is doing probably next year is they'll be putting out scores, but they won't be putting out our final payment adjustments, because during this targeted review process, there's generally lots of changes to the scoring and things. So any of that is possible, but that's not a valid reason for a targeted review. If you had qualified for a reweighting due to some type of uncontrollable circumstance and you made that application, and for whatever it's not reflected in your feedback score, you could request a targeted review. But remember, you need supporting documentation for that extreme and uncontrollable circumstance. And sometimes when you've applied for those EUCs, and then some data inadvertently gets submitted for a couple of categories that'll override your EUC. So it's important to look at these when they come out. Additionally, targeted reviews are time limited within CMS's time frames. They set dates of when you can apply for a targeted review. And then if they request additional information from you, once you request that, you're under a time limit as well to return that information. It's not an infinite amount or an open window. You've got specific time limits. And then I think I'm going to turn it over back to Jessica to wrap us out for the rest of the afternoon.
Thank you, Robin. So now we're going to switch to talking about some individual strategies that you all can employ for improvement to help reduce costs. Now, one of the things to always keep in mind is that this program, and in particularly the cost performance category of MIPS, is to reduce costs of CMS, costs associated with the beneficiary and costs most importantly associated to Centers for Medicaid and Medicare Services. And so that's something to keep in mind. One of the ways, or the primary way that as a practice you can reduce costs, is looking for ways to create efficiency. We have to find that efficiency, but we also have to balance it with our patients' outcomes, right? We can have low costs, but also poor quality, and that's not really going to meet the needs of our organization or satisfy CMS's requirements. We can have high costs and high quality, and CMS is a little bit more okay with that. But ideally, we want to have that equal balance. High cost and, or excuse me, low cost and high quality that balance each other out. So one of the first places to start, and we're going to kind of talk a little bit more in depth about some of these, but you want to look at your cost feedback. You want to be able to assess those benchmarks and see how you compare with your peers. You want to look at ways to improve your clinical documentation. You're going to want to look at ED visits, ED utilization. You're going to want to look at your readmission rates. You're going to want to be able to try to identify ways to provide and enhance access. As we can see, with a lot of these measures, revisits, ED utilization all roll into adding to those additional costs of care. So if you can find ways to redirect your patients to that primary care setting, it's going to be more cost effective long term for them to have their care managed in an ambulatory outpatient setting as opposed to that ED or that inpatient. Now, obviously, there are times when it's best practice to have that patient admitted. And again, that goes back and ties back into that quality of care. Maximizing your annual wellness visits, making sure that if you are doing, if you're monitoring patients for a chronic condition, if you are doing those screenings for breast or colorectal cancer or any of these other types of conditions, that you're addressing these issues, that you are looking at ways to help capture that information to help best provide that preventative care to that population. Identifying populations for care coordination. Who are your most vulnerable populations? Who are your highest utilizers? What are the systems and processes in place that you have to support those patients and their caregivers that are experiencing those issues? We know that some of the most vulnerable times that a patient can have are during those transitions of care. Making sure that if a patient is discharged from your facility or from another facility, that they have a primary care or specialist visit within 7 days post-discharge. There's different things that we can do, and you can also make sure you're maximizing your billing around chronic care management and transitional care management. You also want to make sure that you're leveraging the resources that you have. KHI is a great resource for leveraging that health information, understanding when your patients are discharging perhaps for other facilities, being able to look at outside images from other facilities to help reduce the amount of duplicative imaging, utilizing the Connect resources for social drivers. There's a lot of wealth of information that we have that's free of charge here in the state of Kentucky that not a lot of other states can really boast. So making sure that you are leveraging those already in-house in the state. We also want to make sure that you're looking at your CMS measure information sheets. Those are really those roadmaps for how those measures are built. You can look at the different HCC codes that go into adjusting for risk. You can look at the types of codes that trigger for your patient populations for those cost measures. And so you can reach out to your advisor. We can pull those down for you based on measures that you've been historically assessed on before, or those that you think that you might be eligible to trigger for this year. And again, we are here to help strategize with you across all of your performance categories, including cost. We know that this is a tricky category, and people kind of bristle when we start talking about controlling cost and ways to reduce costs over time, but it's an important conversation to have simply because it matters. It focuses, it's becoming so important to be successful in MIPS, right? You have to maximize every single point that you can get with this program to avoid penalty. So again, just to reinforce historical performance, knowing where you've been, and what you've been assessed on, how many points that you've earned in previous feedback reports. A lot of folks have taken those COVID EUCs and those hardship exceptions for several years now. So you might not actually have patient level detail since 2019. So you are kind of going in blind with this. And that's frustrating, right? 2019 data pre-COVID is not necessarily going to look like anything we've seen before. But if you do have that information, you do want to pull it down. We're hopeful that we'll get more information this year with our practices, those who chose to be assessed on cost. That is something that, that's definitely a way that you can take a look at what your performance is. You want to look at your historical case minimums. If you can look at what you've billed for, looking at those trigger codes for around these measures, that can help you determine if some of these measures are going to be applied to you if you don't have historical performance. And you're going to want to look at that around those three major types of measures, episode, total per capita, and Medicare spending. Again, you're going to want to look at those different claims. You're going to want to be able to look at and to be able to really anticipate and audit those claims, to look at those different criteria of items and services, those different codes, whether they're MSDRG, whether they're HCPCS, or CPT codes, E&Ms, to be able to identify those patients. And now we've kind of stratified this into what to look for both the primary care and specialty care setting. So really your primary care, those strategies that are very specific to your measures, looking at chronic care management, that's best handled in that primary care setting. So what systems, what structure do you have in place if you are seeing primary care patients, you're providing, rendering those services? What are you doing to manage your patients with COPD, with heart failure, with diabetes, coronary artery disease? What programs, what support do you have in place? Are you billing for CCM? As I mentioned before, identifying those patients who frequently utilize, those high cost services, whether that's readmissions or ED utilization. What are processes, what are interventions that you can put in place to reduce those? And then also having a population health focus and a population health mindset, shifting from reactive to proactive or preventative care. Again, utilizing those annual wellness visits to really target your patient's needs. And then in the specialty care realm, Robin talked a little bit about total per capita cost and that attribution, and how sometimes there are primary care E&M services that are billed to a clinician who typically wouldn't be providing primary care. We can see that in pain management. We can see that in oncology. We can see that in cardiology a lot of times. Now, there are some services that CMS does assume, and some specialties that CMS does not adjust for. But in that case, and regardless of if you are being attributed as a specialty clinician, that patient, all you have to do to be able to move that patient out of your bucket because it's maybe not appropriate for you to be viewed as their primary care clinician is to have that patient have at least one visit during the performance year with their primary care provider. So, making a referral back to primary care annually to follow up and to monitor their overall care condition. So that's a great recommendation for specialty care, to start moving your total per capita patients over to that primary care side and out of your bucket if that's not within your scope of practice. Take a look again at the type of E&M codes that you're billing, making sure that they are appropriate for the care that you are providing. And then also, again, looking at duplicative testing. We talked about K-high, looking at your HIEs, making sure that clinicians are able to pull in outside images to be able to, if, in multiple MRIs for a patient, if there's a way to reduce those without putting that patient at risk, that is definitely an intervention, to be able to employ, to be able to make sure that our clinicians have access to high quality images so that they can make informed decisions. And across both, we've already talked about this, but essentially we want to make sure that we're hardwiring safety, that we're focused on harm reduction, that you're looking at how to improve access, right? Whether it's extending clinic hours, whether it's utilizing your advanced practice providers to their full licensure. We can see there's sometimes that's really something that is an underutilized resource that you have at your fingertips. Utilizing your PAs, your nurse practitioners, to be able to deliver some services, to be able to provide some more access to your MDs. And again, looking at that communication piece, how are you coordinating care with those other providers that touch your patients, whether that's internal or that's external to your organization? As we continue with this program, and really just as we shift as a healthcare industry to that population health mindset, it's becoming more and more mission critical to be able to leverage that communication and managing that patient's care at a more holistic, systematic level. So again, just a kind of a refresh of some of the action steps that you can take. Start with those measure information sheets. Reach out and your advisor can pull those for you. You can also find information from field testing measures. Those measures might not be eligible for this performance year, but odds are they're probably going to be coming down the pike. So if you trigger for those measures, that's a good indication that you will be scored on it in a future year and you can perhaps prepare for it. Again, you want to look at your measure attribution. You want to review any of those trigger codes that could bring that patient into your denominator, looking at your cost performance, confirming your billing practices. Are your providers admitting patients? What are the primary care services that you're billing for? What kind of procedures and episodes would you potentially bill for in your tax ID? And then again, monitoring your high risk, high acuity patients and tracking them through the system. There's several different links to cost resources in our outreach email that we'll send. We'll give you links to these, but again, as a provider or as a providing practice that works with us, we are happy to dig down into any of these measures with you and be able to help you once that information from the feedback from the QPP feedback portal is updated for 2023, we can dig down into cost more specifically and more targeted. And then I just want to open it up to questions for any of our attendees today. If you have any questions, please feel free to plug them into the chat. We are happy to help answer those. If you are more comfortable reaching out to your advisor directly, please feel free to do so as well. We are here to help you navigate this sometimes painful category. Just as a reminder, we do have a couple more webinars coming up. These are going to be pre-recorded so you can access them at any point in time at your convenience. We are going to have, hopefully CMS will get those released, but we are going to be doing a pre-recorded video for you around those specific feedback reports and your final scores. Talking more in depth about that targeted review process and the timelines. And then we're also going to be releasing a pre-recorded video on promoting interoperability and improvement activities, a performance category overview. Again, if you have missed any of our recordings, would like copies of slides, please reach out to your advisor. We're happy to pull those together for you. And then also one last thing, we are going to be hosting our annual conference. This year's theme is Innovating for Better Health Outcomes. please feel free to scan that QR code to register. Again, this will be sent out, a PDF of the slides will be sent out here in the coming days. So that you can also use that. But we're going to be talking about quality improvement. We're going to be talking about HIPAA, social drivers, hospital PI, and we're going to have some really great speakers lined up for you all. So hopefully you can join us at the Campbell House on Thursday, October 24th. And then I do not see any questions in the chat or Q&A. So again, if you have them, please don't hesitate to reach out to us. We are here to help you. And again, if you ever have any questions, you can't get a hold of your advisor, you can always reach us at kyrec@uky.edu or at 323-3090. And with that, we will conclude the webinar, and we hope to talk to you soon. Have a great day.